Picture this: Margaret, a vibrant 73-year-old grandmother, enters her doctor's office with a spring in her step and leaves with a prescription for 5 different medications and scheduled for 3 more tests. 6 months later, she's dizzy, weak, and afraid to leave her house. Sound familiar? What if I told you that Margaret's story isn't unique, and that millions of seniors are trapped in a medical maze that's stealing their golden years? Today, we're uncovering the shocking truth about modern healthcare for seniors and revealing why sometimes less medicine means more life. Dr. Sarah Chen had practiced family medicine for over 2 decades, but it wasn't until her own father turned 75 that she truly understood the monster she'd been feeding. Her father, Robert, was a retired carpenter who spent his days building birdhouses and teaching his grandchildren woodworking. He was healthy, active, and genuinely happy. Then came his annual physical. What started as a routine checkup spiraled into what Dr. Chen now calls the cascade of care, a relentless series of tests, specialists, and procedures that transformed her vibrant father into what she describes as a professional patient. The journey began innocently enough. His PSA levels were slightly elevated, not unusual for a man his age, but the protocol demanded further investigation. One test led to another, then another, until Robert found himself scheduling more medical appointments than social gatherings. The psychological impact was immediate and devastating. Robert, who had once approached each day with enthusiasm, began each morning by checking his pill organizer and reviewing his appointment calendar. The man who had built hundreds of birdhouses with his own hands now questioned whether he had the energy to lift a hammer. The fear of what the next test might reveal consumed his thoughts, replacing the joy of creation with the anxiety of anticipation. Dr. Chen watched her father's transformation with growing alarm. The medical system, designed to heal and protect, had become a prison of protocols and procedures. Each specialist saw only their piece of the puzzle. The urologist focused on his prostate, the cardiologist on his heart, the endocrinologist on his blood sugar. Nobody was looking at Robert as a whole person, considering what truly mattered to him at this stage of his life. The financial burden was equally crushing. Despite having Medicare and supplemental insurance, the copays, deductibles, and out-of-pocket expenses mounted quickly. Robert's retirement savings, carefully accumulated over decades of hard work, began evaporating in the face of medical bills for tests that yielded ambiguous results and treatments that caused more problems than they solved. But perhaps most tragic was the loss of time. Robert's remaining years, which should have been filled with woodworking, storytelling, and watching his grandchildren grow, were instead consumed by waiting rooms, medical procedures, and recovery from unnecessary interventions. The very system meant to preserve his life was stealing his ability to live it. This phenomenon isn't isolated to Dr. Chen's family. Across the country, seniors are caught in what researchers call medical overuse, the application of medical interventions when they're unlikely to provide benefit. A comprehensive study by the Lown Institute found that over 50% of seniors receive at least one unnecessary medical service each year, with the average senior undergoing 2.3 potentially harmful procedures annually. The root of this problem lies in a healthcare system designed around acute care for younger patients, not the complex, nuanced needs of aging adults. Medical guidelines, often developed from studies of younger populations, are applied uniformly to seniors without considering the fundamental differences in how aging bodies respond to interventions. The result is a one-size-fits-all approach that ignores the individual circumstances, preferences, and remaining life expectancy of older adults. Consider the case of routine cancer screenings. While these tests can be life-saving for younger adults, their value becomes questionable for seniors with limited life expectancy or multiple health conditions. An 85-year-old with dementia and heart disease may undergo a colonoscopy that requires uncomfortable preparation, carries risks of complications, and even if it detects early-stage cancer, may not improve their quality of life or longevity. The medical profession's defensive medicine practices further exacerbate the problem. Fear of malpractice lawsuits drives doctors to order tests and procedures not because they're medically necessary, but because they provide legal protection. This creates a vicious cycle where seniors receive excessive care not because it benefits them, but because it protects their doctors. The tragedy of medical overuse extends beyond individual patients to families and communities. Children and grandchildren watch their loved ones decline not from natural aging, but from the cumulative effects of medical interventions. The strong, independent parents and grandparents they once knew become frail, dependent, and increasingly disconnected from the activities and relationships that once defined their lives. Dr. Chen's awakening came during a particularly difficult period when her father was hospitalized following a reaction to a medication prescribed to treat a condition that likely didn't require treatment. Sitting by his bedside, she realized that the medical system she had dedicated her career to was failing the people it was meant to serve. Her father's story became a catalyst for her own transformation as a physician, leading her to question every recommendation, every test, and every prescription she offered to her older patients. The solution isn't to abandon medical care entirely, but to fundamentally reimagine how we approach healthcare for seniors. This requires a shift from the current model of aggressive intervention to one that prioritizes quality of life, functional independence, and alignment with patient values and preferences. It means having honest conversations about what truly matters to seniors and designing care plans that support those priorities rather than following rigid protocols developed for different populations. As we'll explore in the coming chapters, this transformation requires courage from patients, families, and healthcare providers to challenge the status quo and embrace a more thoughtful, individualized approach to senior care. The goal isn't to avoid all medical care, but to ensure that every intervention serves the ultimate purpose of enhancing life rather than merely prolonging it. Eleanor Martinez had always been what her family called tough as nails. At 78, she still maintained her own garden, cooked elaborate Sunday dinners for her extended family, and served as the unofficial neighborhood watch coordinator. Her secret, she often joked, was that she avoided doctors like the plague. But when her daughter insisted on a wellness check after Eleanor experienced a minor dizzy spell, the cascade began. The initial visit seemed harmless enough. Eleanor's blood pressure was slightly elevated, her cholesterol levels were higher than current guidelines recommended, and her bone density scan showed some expected age-related changes. Within an hour, she left the office with 3 new prescriptions and scheduled for 5 follow-up appointments. Her daughter felt relieved that they were being proactive about Eleanor's health. Eleanor felt overwhelmed but trusted the medical professionals. The first medication, a statin for cholesterol, seemed innocuous until Eleanor began experiencing muscle pain that made her evening walks uncomfortable. When she mentioned this to her doctor, he prescribed a different statin, which caused digestive issues that left her feeling nauseated and weak. The blood pressure medication made her dizzy, ironically worsening the symptom that had brought her to the doctor in the first place. The calcium supplement for her bones caused constipation, leading to yet another prescription for a laxative. Within 3 months, Eleanor's medication list had grown from 0 to 8 different prescriptions. Her kitchen counter, once clear except for a coffee maker and a bowl of fresh fruit, now resembled a pharmacy with pill organizers, bottles, and a complex schedule of when to take what medication with or without food. The woman who had once prided herself on her mental sharpness now struggled to remember which pill was which and frequently worried about dangerous interactions. The physical effects were devastating. Eleanor's energy levels plummeted, her appetite disappeared, and the muscle pain made her gardening impossible. But perhaps more concerning was the psychological transformation. Eleanor, who had always been confident and independent, began second-guessing herself constantly. She became afraid to drive, worried about falling, and increasingly dependent on others for tasks she had easily managed before her wellness intervention. Her family watched with growing concern as Eleanor seemed to age a decade in just a few months. The vibrant woman who had been the cornerstone of their family gatherings became withdrawn and anxious. Her famous Sunday dinners became a thing of the past as she struggled with nausea and fatigue. The garden that had been her pride and joy became overgrown as she lacked the strength to maintain it. This phenomenon, known as polypharmacy, affects nearly 40% of seniors and is one of the most dangerous aspects of modern healthcare for older adults. The human body's ability to process medications changes significantly with age. Kidneys and liver function decline, making it harder to eliminate drugs from the system. Muscle mass decreases while fat increases, altering how medications are distributed throughout the body. These changes mean that dosages appropriate for younger adults can be toxic for seniors. The situation becomes exponentially more dangerous when multiple medications are involved. Drug interactions can create unpredictable and potentially fatal side effects. A blood pressure medication might interact with a cholesterol drug to cause dangerous drops in blood pressure. A pain reliever might interfere with a heart medication, reducing its effectiveness. The complexity of these interactions is so great that even experienced pharmacists struggle to predict all possible consequences. Eleanor's case illustrates another critical issue: the treatment of normal aging as disease. Her slightly elevated blood pressure and cholesterol levels, while outside current guidelines, were not necessarily pathological for a 78-year-old woman. Her bone density, while lower than a 30-year-old's, was typical for someone her age. By treating these normal age-related changes as diseases requiring aggressive intervention, the medical system transformed a healthy, independent woman into a sick, dependent patient. The economic impact of this cascade is staggering. Eleanor's monthly medication costs exceeded $400, not including copays for frequent doctor visits and periodic lab tests to monitor for drug side effects. Her family spent thousands of dollars on medications that were making her sicker, not healthier. The financial burden was compounded by the indirect costs of lost independence, hiring help for tasks Eleanor could no longer perform, modifying her home to accommodate her new frailty, and the emotional cost of watching a loved one decline. Unnecessarily, the medical system's response to Eleanor's deterioration was predictable: more interventions. When she complained of muscle pain, the solution was a different medication. When she experienced dizziness, the answer was adjusting dosages. When she developed digestive issues, another prescription was added. Each new symptom was treated as a separate problem requiring its own solution, rather than recognizing that the treatments themselves were the source of her problems. This approach reflects a fundamental flaw in how modern medicine views aging. Instead of understanding aging as a natural process with its own rhythms and requirements, the medical system treats it as a collection of diseases to be fought with an ever-expanding arsenal of interventions. The focus shifts from supporting healthy aging to preventing every possible age-related change, regardless of whether those changes are actually harmful or whether the treatments cause more problems than they solve. Breaking free from this cascade requires a fundamental shift in perspective. Instead of asking what can we treat, the question should be what should we treat. This requires considering not just the potential benefits of an intervention, but also its risks, the patient's remaining life expectancy, their personal values and preferences, and the impact on their quality of life. Eleanor's story had a relatively happy ending. After 6 months of declining health, her family insisted on a comprehensive medication review with a geriatrician who specialized in senior care. One by one, most of Eleanor's medications were discontinued or reduced. Within weeks, her energy began to return. Within months, she was back in her garden, planning her next Sunday dinner, and reclaiming her independence. The transformation was remarkable, not because of medical intervention, but because of the removal of unnecessary medical intervention. Dr. Michael Thompson learned the most valuable lesson of his medical career not in medical school or during his residency, but while sitting in his 82-year-old patient's living room, surrounded by photo albums and the aroma of homemade cookies. Martha Williams had been his patient for 15 years, and he had dutifully followed every guideline, ordered every recommended test, and prescribed every indicated medication. Yet as he sat there, listening to Martha describe how medical appointments had consumed her life, he realized he had been asking the wrong questions. Martha's story was heartbreakingly familiar. She had been a retired teacher who spent her days volunteering at the local library, tending to her rose garden, and caring for her elderly neighbors. Her life had purpose, joy, and meaning. Then came the cascade of medical interventions that gradually stripped away everything that made her life worth living. Doctor appointments consumed entire days, medication side effects left her too tired for activities she loved, and the constant worrying about test results replaced the peace she had found in retirement. That afternoon, Dr. Thompson asked Martha a question he had never posed to a patient before: "What matters most to you?" Her answer changed everything. She didn't want to live to 100 if it meant spending her remaining years in waiting rooms and managing medication side effects. She wanted to tend her roses, read to children at the library, and have the energy to cook for her friends. She wanted to die peacefully in her own bed, surrounded by the people she loved, not in a hospital surrounded by machines. This conversation marked the beginning of Dr. Thompson's transformation from a protocol-following physician to a practitioner of what he now calls selective care, an approach that prioritizes quality of life over quantity of interventions. Selective care doesn't mean abandoning medical treatment. It means choosing treatments that align with the patient's values, preferences, and realistic life expectancy. The principles of selective care are deceptively simple but revolutionary in their application. First, every medical intervention must be justified not by guidelines or protocols, but by its potential to improve the patient's quality of life or achieve goals that matter to them. Second, the risks and benefits of any treatment must be evaluated in the context of the patient's overall health, remaining life expectancy, and personal values. Third, the patient's autonomy and preferences must be respected, even when they conflict with medical recommendations. Consider the case of William Chen, a 79-year-old retired engineer with mild cognitive impairment and a passion for woodworking. Standard guidelines would recommend aggressive cholesterol management, regular colonoscopies, and intensive monitoring of his blood sugar. But William's priorities were different. He wanted to maintain his independence, continue his woodworking hobby, and avoid the cognitive fog that many medications can cause. Through selective care, his treatment plan focused on interventions that supported these goals while avoiding those that might compromise them. William's cholesterol was managed through dietary changes and regular walking rather than medications that might affect his mental clarity. His colonoscopy was deferred because his life expectancy and cognitive status made it unlikely to provide meaningful benefit. His diabetes management focused on preventing dangerous highs and lows rather than achieving textbook perfect numbers that might require medications with cognitive side effects. The result was remarkable. William continued his woodworking for 3 more years, creating beautiful pieces for his grandchildren and maintaining his sense of purpose and identity. He avoided the medication-induced confusion that plagued many of his peers and remained independent until the final months of his life. When he eventually passed away peacefully at home, his family felt grateful that his final years had been truly lived rather than merely medically managed. Selective care requires a fundamental shift in how we measure success in healthcare. Instead of focusing on laboratory values, test results, and adherence to guidelines, success is measured by the patient's ability to maintain dignity, independence, and engagement in activities that bring meaning to their lives. This approach recognizes that for many seniors, the goal is not to maximize longevity at any cost, but to optimize the quality of their remaining years. The implementation of selective care requires honest conversations between patients, families, and healthcare providers. These discussions must address difficult topics. What are the patient's priorities and values? What kind of life do they want to live? What are they willing to sacrifice for potential medical benefits? What risks are they willing to accept? These conversations are often uncomfortable, but they are essential for creating care plans that truly serve the patient's best interests. Dr. Thompson's practice now begins every senior patient encounter with what he calls the values conversation. He asks patients to describe a typical good day in their lives, to identify what activities and relationships matter most to them, and to share their fears and hopes about aging. Only after understanding these priorities does he discuss medical interventions, always framing them in terms of how they might support or interfere with the patient's goals. The selective care approach has transformed not only his patients' lives but also his own satisfaction as a physician. Instead of feeling like a protocol-following technician, he has become a true partner in his patients' care, helping them navigate the complex landscape of aging while preserving what matters most to them. His patients report higher satisfaction with their care, better quality of life, and greater peace of mind about their medical decisions. The resistance to selective care often comes from family members who fear that choosing less aggressive treatment means giving up on their loved one. Dr. Thompson spends considerable time helping families understand that selective care is not about abandoning hope, but about redirecting hope toward achievable and meaningful goals. Sometimes the most loving thing family members can do is support their loved one's choice to prioritize quality of life over quantity of medical interventions. The selective care approach also requires healthcare systems to restructure their incentives and measurements. Instead of rewarding physicians for following protocols and ordering tests, Systems must recognize and reward providers who help patients make informed decisions that align with their values and goals. This shift requires courage from healthcare leaders to prioritize patient-centered outcomes over easily measured metrics. As we move forward, the challenge is to expand selective care beyond individual physicians and patients to entire healthcare systems. This requires training healthcare providers in communication skills, developing new ways to measure quality that focus on patient-reported outcomes, and creating payment structures that reward thoughtful, individualized care rather than volume-based interventions. The revolution in senior healthcare isn't waiting for policy changes or institutional reforms. It's happening in living rooms, examination rooms, and family gatherings across the country, led by courageous seniors and their families, who are choosing to reclaim control over their medical decisions. The path forward requires both individual action and collective change, but it begins with understanding that you have the power to choose a different way. Margaret Foster represents this new generation of empowered seniors. At 76, she had watched her friends become consumed by medical appointments, medication side effects, and the constant anxiety of managing multiple health conditions. When her own doctor recommended a series of tests and treatments that seemed designed more to follow protocols than to address her actual needs, Margaret made a radical decision. She fired her doctor and found one who practiced what she now calls collaborative care. Her new physician, Dr. Sarah Kim, began their relationship with an unusual question: what does a good life look like for you? Margaret's answer was specific and heartfelt. She wanted to continue her weekly bridge games with friends, maintain her small apartment independently, and have the energy to enjoy visits with her grandchildren. She was less concerned about preventing every possible future health problem and more focused on maintaining her current quality of life. Together, they created a healthcare plan that supported Margaret's goals rather than following a standardized protocol. They focused on interventions that would maintain her independence and cognitive function while avoiding treatments that might compromise her quality of life. Margaret's medication list was simplified. Her testing schedule was reduced to only those screenings that would actually change her treatment decisions, and her appointments became collaborative conversations rather than one-sided medical consultations. The transformation was remarkable. Margaret's energy increased, her anxiety about health issues decreased, and she reclaimed the time and mental space that had been consumed by medical management. Her bridge games became regular again, her apartment remained a source of pride, and her relationships with her grandchildren deepened. Most importantly, she felt in control of her own life again. Margaret's approach illustrates the 5 key principles of taking control of your healthcare after 70. First, become an informed advocate for yourself. This doesn't mean becoming a medical expert, but it does mean understanding your values, priorities, and preferences well enough to communicate them clearly to your healthcare providers. It means asking questions like, how will this test or treatment help me achieve my goals? And what happens if I choose not to pursue this intervention? Second, find healthcare providers who respect your autonomy and are willing to partner with you in making decisions. This may mean changing doctors, seeking second opinions, or specifically looking for providers who specialize in geriatric care and understand the unique needs of older adults. The right provider will listen to your concerns, respect your preferences, and work with you to create a care plan that aligns with your values. Third, simplify your medical management whenever possible. This might mean consolidating care with fewer providers, reducing the number of medications you take, or eliminating tests and procedures that don't serve your specific goals. Every intervention should earn its place in your care plan by demonstrating clear benefits that outweigh its risks and costs. Fourth, prioritize interventions that maintain your independence and quality of life. This might mean focusing on physical therapy to maintain mobility rather than medications that might cause cognitive impairment, or choosing treatments that can be managed at home rather than those requiring frequent hospital visits. The goal is to support your ability to live the life you want rather than simply extending life at any cost. Fifth, engage your family and friends in your healthcare decisions. Make sure they understand your values and preferences so they can support your choices and advocate for you if you become unable to speak for yourself. This might mean having difficult conversations about end-of-life preferences, but these discussions can provide peace of mind and ensure that your wishes are respected. The path forward also requires systemic changes in how healthcare is delivered to seniors. Healthcare systems must move beyond the current model of episodic, protocol-driven care to embrace a more holistic, patient-centered approach. This includes training healthcare providers in communication skills, developing new quality measures that focus on patient-reported outcomes, and creating payment structures that reward thoughtful, individualized care. Educational initiatives are crucial for empowering seniors to take control of their healthcare. This includes providing resources about the risks and benefits of common interventions, teaching communication skills for interacting with healthcare providers, and creating support networks for seniors who are navigating complex medical decisions. Community organizations, senior centers, and healthcare systems all have roles to play in this educational effort. The role of family members is equally important. Adult children and other family members need to understand that supporting a senior's autonomy sometimes means accepting decisions that prioritize quality of life over aggressive medical intervention. This requires shifting from a mindset of doing everything possible to one of doing what's best for the person we love. Technology can also play a supportive role in this transformation. Electronic health records that track patient values and preferences, decision-making tools that help seniors understand their options, and communication platforms that facilitate better interactions between patients and providers all have the potential to improve the quality of healthcare for seniors. The ultimate goal is not to eliminate medical care for seniors, but to ensure that every intervention serves the purpose of enhancing life rather than merely prolonging it. This requires courage from patients, families, and healthcare providers to challenge the status quo and embrace a more thoughtful, individualized approach to senior care. As we move forward, the stories of seniors like Margaret Foster serve as inspiration and guidance. They show us that it's possible to age with dignity, maintain autonomy, and prioritize quality of life without abandoning appropriate medical care. They demonstrate that the path forward is not about choosing between too much care and too little care, but about choosing the right care for each individual at each stage of their journey. The revolution in senior healthcare is not just about changing medical practices, it's about changing our entire approach to aging. It's about recognizing that the goal of healthcare should be to support a life worth living, not simply to extend life at any cost. And it's about empowering seniors to take control of their own healthcare decisions and live their golden years on their own terms. The choice is yours. The path forward begins with a single step, deciding that you deserve healthcare that serves your goals, respects your values, and supports the life you want to live. The journey may not be easy, but it leads to a destination worth reaching, a healthcare experience that truly enhances rather than diminishes your golden years.